Hi, welcome to Fertility Talks. I'm Mary Wong, your host and founder of Alive Holistic Health Clinic, author of Pathways to Pregnancy, acupuncturist, as well as your fertility strategist. Here we are with Dr. Cliff Librach, and I'm so excited to have him here. And it is 8:30 at night, and guess what? We're both workaholics, and we're both working, and we came on. I hope you've had dinner. I had to shove some dinner down my throat, and we're here at Create. And tonight we're going to be talking about how to help you conceive while you are experiencing low ovarian reserve. And before we get into the meat of this topic, I'm just going to introduce you to Dr. Librach. Before I say anything else, I'm just going to divulge some information. He was my fertility doctor, okay? So
luckily she was successful.
Yeah. Right, because otherwise I wouldn't be interviewing you. Oops. Anyway, so aside from that, he is, again, Dr. Clifford Librach. He's a reproductive endocrinologist and infertility specialist, and he basically was trained in the University of California in San Francisco. He is a professor at the U of T for OBGYN, right?
Correct.
And researcher, and he's a founder and director of Create Fertility Center in Canada, and I think it's one of the largest centers in Canada.
Definitely.
Yeah, and you also run the largest REI research, reproductive endocrinology and infertility research program in Canada, and formed the Create Biobank Preserve Waste Material for REI research. And he was the former president just last year for the Canadian Fertility and Andrology Society. So he has published over 120 peer-reviewed publications, over 500 abstracts, and 5 book chapters. So welcome.
Thank you.
So he's a busy
Pleasure
man.
to be here. And
yeah,
I'm a busy man.
He's
right.
a busy man, and he's making the time. And so I really want to, honor you for taking the time out, because this is literally, this is my passion, and I want to help people. We created Fertility Talks to give you really great information based on the latest research and through fertility experts like Dr. Librach, and then for those who have gone through it before you, to give you accurate information so you don't get misinformed. There's a lot of junk on that Dr. Google puts out, right? So unfortunately, and so we're here to set things straight. So let's get right into it.
And I want to compliment you. I think this is an unbelievable thing you're doing to help people get informed, to get proper information so they can make informed decisions about their care.
Absolutely. Thank you so much. Yeah.
Thank you.
Oh. Okay, so very first thing, I guess, for those who don't know, what provides you the parameters to say you have low ovarian reserve?
So that's a great question. And we know that as women get older, they have less and less eggs. And of course, when you go through menopause, you sort of run out of eggs at that point. But the problem is that there are some women who can be born without eggs, and also they can go through premature loss of eggs, so that they go through menopause earlier than somebody would normally go. The average age is about 49, 50, but there are many women that go through much earlier, and they can have problems with producing eggs, especially if they waited longer to start trying to conceive.
Right.
Now, there are 2 main ways that we test the ovarian reserve. The first is the ultrasound, looking at the ovaries, and we call that the antral follicle count. So we count the number of eggs early in the cycle. The problem with that one is it can vary from month to month, and it can also vary from ultrasound technologist to ultrasound technologist, because the ovary is a 3-dimensional structure, and you're trying to count how many follicles within a 3-dimensional structure when the ultrasound is a 2-dimensional structure, so 2-dimensional machine. So it's very hard to do, and so the accuracy of that is okay, but not anywhere near as good as the new test that we have, which is called the anti-Müllerian hormone, or AMH. So if anyone is interested in looking at their own fertility, that test is probably the most accurate way of doing it. It should be done in a center that does a lot of them, because there is variation in the ability for the machines and the kits to do the proper job. but I think it is an amazing test, and I do it pretty well on every patient that comes to
Right.
me, because I want to know what their ovarian reserve is and how I can best help them, and whether they're going to be in sort of a situation where waiting a long time could be really impair their fertility.
Right. So, and I love how you say that the ultrasound is not as accurate as people might think it can be. Do you have like a percentage accuracy?
You know, I would say that compared to the AMH, the anti-Mullerian hormone, it's probably only about 60 to 70% as accurate.
Okay, and as you say, and when we look at it from month to month, there is a variance, right? So
That's
some
right.
cycles you may have double the amount of another cycle.
Mm. And there's another test that we used to do, which is a blood test called the Day 3 FSH. And again, that's helpful, but now AMH has really surpassed both of those tests in helping us know if someone has an ovarian reserve.
Yeah.
And we can follow it over time and watch how the ovarian reserve goes.
Right, and so to clarify for those who have been in and around, FSH is a follicle stimulating hormone, and that we also do see vary from month to month as well. So I remember that it used to be you're as good as your highest FSH.
Yes.
But now we know that's not accurate.
That's correct.
Okay, so then as a more reliable indicator, but does that mean, like, what does it really mean? Like, if you have low ovarian reserve, does it mean you can't have a baby? Does it mean your eggs are bad? How do you
That's
make
a
it mean?
great question. And I think what people don't always understand is there's a difference between the quantity and the quality of your eggs. So the quality, I don't really have a way of testing that so much in a blood test or anything. That's really related to your age. And as women get older, unfortunately, the number of eggs they have goes down. That's the quantity, but the quality is still related to your age. So if you're younger and you have a low reserve, say you're 34 or 33, and fortunately you have a low reserve, your eggs are going to be better quality. You may not have as many, but your eggs are be better quality. So I'd rather have someone who is younger with less eggs than someone older with more eggs, because lots of bad eggs doesn't necessarily make a baby. So I think it's really important to distinguish the quality and the quantity. Unfortunately, both go down with age, but if you're younger and you have a low reserve, your chances of success is higher.
That I totally will not argue, but I just don't want to overlook the fact that it doesn't mean that you don't have any good eggs.
That's correct. So,
Because otherwise people will hear and they're going to get totally depressed.
No, and we're going to get into this because there are ways that we can optimize things for people with low reserve. Even if they are older and they have less eggs, there are things that we can do, and we're going to talk about that.
Yeah, so why don't we go straight into that?
Okay, great.
Yeah.
So, like I said, if you're older, the quality of your eggs is less, but it doesn't mean you don't have good eggs in there somewhere. You may not, but it means that we need to likely have more to be able to produce a healthy baby. And so there are some techniques that we use in our clinic to help when they have a low reserve. One of them is to add adjuvant sort of supplements that we use. And in our clinic, we use, one of the supplements we use is called DHEA, or dihydroepiandrosterone. Don't have to remember that name, but it's basically a natural hormone that we make from the adrenal glands, which are the glands above the kidney. And all of us make that. We actually derive it when we give it for people from yams. It's made by plants as well, the exact same hormone. And DHEA, actually, it's interesting that is the highest concentration of hormone in the body of a person when they're young, like in a teenager. And it also is related to libido. So when I put people on DHEA, I always tell them you may have a little bit higher sex drive. That's not a bad thing. That's one of the, I call it the side effect, but most people don't mind that one. It does also, it is also like an androgen or a male type hormone. So some people get a bit of extra hair growth or potentially acne with it, but most people do very well with it. And there are actually studies showing that DHA may actually extend longevity. So, and that's been sort of hypothesized because young people have so much of it in their body.
So then my question is, Are you looking at the blood work for DHEA before you put people on it, or and testosterone and estrogen, or do you just, irrelevant of the blood work, you'll still put them on?
Yeah, it doesn't really help us. I think that the DHA, what it does, and we've published papers on it, it makes your ovaries more responsive to the medications. So you tend to make more eggs when you're on the DHA, in my experience. The other two hormone supplements we use are to help the mitochondria. These are little energy packages in the cell, and the eggs have the most mitochondria of any cell in the body. So we'll use a compound called coenzyme Q10, which is also a natural substance. It's good for our heart and everything like that, and many other parts of our body. And that one we tend to use a little bit higher dose to help those little energy packages. In addition, we use another compound called PQQ, and I'm not going to tell you what that stands for. It's a very long name, but it's another natural vegetable-derived compound that helps the energy packages. And the two of them work together to enhance those little mitochondria, because eggs need a lot of energy to be able to fertilize and produce embryos. So that's the sort of strategy that we use. There are other things that people use as well, but those are the ones that I think have the most evidence.
Right, absolutely. And so we were looking at CoQ10 and PQQ. I do talk about this, and you know what? There's a live post number 65 on looking at supporting egg quality and diet and lifestyle. So looking at foods and actually what you're doing in your lifestyle too. And so if I might add in too, we're looking at more and more there's interest on integrative medicine, and acupuncture is a part of this. And very recently, in the last year, there were two studies, one out of Australia and I believe the other in UK. I'll have to reconfirm that with you, but one is from oh my goodness, I'm losing my mind for a second. Oh, Mike Armour, okay, out of Australia, and they were looking at acupuncture in terms of dosing. So I'll relate it to, you know, when you're trying to superovulate a woman with drugs, you're not going to use it just once, right? You're going to have a consistent dosing over time to create more follicles, help its growth, all that. Well, with acupuncture, now there's more theory and looking at, well, you know what, 1 or 2 sessions might not be enough, and because one of the things that the attempt is to help increase the ATP in the cells, in the mitochondria. So similar to CoQ10, as well as we know it increases blood volume to the ovaries. So the other theory is that perhaps increasing the blood volume, you're also helping to get the CoQ10 and PQQ to the cells where you want it to be, right? So some of the diminished ovarian reserve protocol out of China prior to this has come out with where they're actually using acupuncture 5 times a week for 3 months for the diminished ovarian reserve, and they've seen some really great progress. So there's, you know, this is all just research coming out now, so there'll be much more interest in it. So I was just talking to Dr. Librach and saying that maybe we should actually do research with that.
I think it would be great. I mean, there are some trials with acupuncture that where some said it was better and some not, but I think with the diminished ovarian reserve, it's a whole new area that I think we need to do some really good research and find out.
Yeah, absolutely. And the ones that you're speaking of for the past 7 to 10 years, they were really looking specifically only at 2 acupuncture treatments, which is at the time of embryo transfer, which has nothing to do with egg and egg quality, right? Sure. It's looking at the uterine lining and the relaxation of the uterus. So we're looking at a whole different ballgame. And so it'll be really interesting to look at that.
So the next thing I wanted to talk about, if that's okay with you, is to talk about how we help people get pregnant when we do techniques like in vitro. So most of the time we'll try, you know, natural and timing things, and sometimes we'll do insemination if there's a sperm problem, but we don't want to spend a lot of time on those techniques when somebody has a low reserve, because we don't want to waste a lot of time. Each month counts, and the key is you got to get to the treatment that's going to help them have a baby as quickly as you can. And so when we talk about doing in vitro fertilization, which is often the step that we go to with people with low reserve, you know, on top of all of these adjuvant treatments like the supplements and potentially acupuncture as well, we have to stimulate the ovaries well in order to get the best results. And what we found, we used to stimulate the ovaries really hard because we thought, oh, they're not making enough eggs. Let's try to get more eggs and give high doses of drugs. And it became apparent over the years that actually that's a bad approach for people with low reserve.
Absolutely.
Because the ovaries don't do well. You're actually almost creating a toxic environment for the eggs, because if you just give more drugs, they don't, the ovaries can't respond to them. There's no receptors, as we call it, to the drugs, and they just pee them out. And you're basically spending a lot of money for nothing. So the whole idea now, the concept is this less is more. That you have to be gentle with ovaries that don't have a good reserve. So we actually use lower doses and we get better results. And we published a paper not too long ago that showed that we had double the pregnancy rate when we used a lower dose, we call it minimal stimulation, compared to a high dose. So now that's really the way things are going more, in terms of being more gentle and letting the ovaries do their job, but not pushing them beyond what they're capable of doing. So there are other things that we're also doing now that I'm really excited about. And in terms of the medications, we're now adding some things that can help enhance the responsiveness in addition to the DHA. Some people use, instead of DHA, testosterone cream. That can also work very well, but we just use the DHA because it's easier to take a pill than to put gel on you all the time. It's kind of messy, and we find that it works very well. But the other one is called growth hormone, and we use growth hormone for kids, to help them grow when they're short, stature, and they have to take that for several years, and it does work very well for them to increase their growth. Not, they don't get really, really tall, but they get taller than they would have been naturally.
I should have had some.
And it's a natural hormone. We all make growth hormone. But what we found over the years is that growth hormone may actually help the eggs grow more and get more eggs and better quality. And so we're using more and more of that in our low responders, and we're getting fantastic results with it. And if you can read on Google it, you can see there are many studies now showing that growth hormone improves the pregnancy rates in women who have a low reserve. So that, I think, is a really good point to consider. If you're seeing a doctor and they're not putting you on growth hormone, or they're using too high a dose, consider either a different clinic or asking your doctor to change the approach, and that might do better for you. So the other thing that's really important is we know when someone has a low reserve, they're not going to respond as well, to the drugs as someone with a high reserve, like polycystic ovary syndrome and all those things, which I'm sure you've talked about. They're going to have less embryos. And the key here is that we have to accept that that's the case. So we do something called batching. So we know, like, let's say you were 38 or 39 or 40, and your goal is to have 2 children. Well, you're never going to be 38, 39, or 40 again. So if you get pregnant now, and lucky to get pregnant, and you come back when you're 42 or 43, your chances aren't going to be so great of having another baby. They're going to be less. So what you can do now is you can collect embryos that can be then tested all together to make sure they're normal with genetic testing. And we have a program in our clinic we call 3 for 2. So it means that you do 2 cycles, which are paid for, but then you get a third free. So that's kind of a thing that we've done to help people who have these low reserves to understand that you can't necessarily get what you need from just one cycle. You have to accept that you're just not going to make. And if you try to push your ovaries really hard, like I see some doctors do, and I try to train my younger doctors not to do this, you're not going to get very good results. And so even though you may have, in Ontario, we have a funded cycle, 1 cycle, we always tell people, like, you may have to do more cycles to get what you want. And if you can get normal, if you can do the PGS testing and know they're normal, especially when you're 40, 41, then you're not wasting time putting abnormal embryos inside, or you might have a failure or a miscarriage or an abnormal baby growing inside you. This way you can put normal embryos in, which have a much higher success, of course, and then you're going to avoid all of those complications. Not every normal embryo will make a baby, so you have to realize you may need several of them to be able to create your family that you've always dreamed of.
And I really love it that you actually mentioned that, because I don't want people to believe that if you have a chromosomally normal PGS or PGTA tested embryo that it amounts to a take-home baby right away. And I believe, and you may correct me, 1 in 3, correct? Is that about 98%?
We get 1 in 3
to get a live birth. So if you have 3 PGTA normal embryo, it's
we actually get higher than that, which
okay.
I'm really proud of.
All right.
It's about 70% of the
Okay.
embryos that we put in there are normal. In our clinic, we've noted to have a good healthy pregnancy. So, but there are definitely in the 30 or 40% of embryos that are normal do not take, and there's many reasons for that. That may be a subject of another
complex.
show.
Yeah, that's complex.
It's a complex thing.
Yeah.
But the key, points I've made, I think, are so critical for low reserve patients who are often told, you'll never have children, you have to go through an egg donor, and yes, that's an option, but egg donation is not time sensitive. You can do that at almost any age. You go through full menopause for the last 5 years, it wouldn't matter, you still have the same success rate. So egg donation you can always do, but before you get to that stage, I think now in the current times, and I've been practicing for almost 30 years, so I was one of those people giving these high doses of drugs and not understanding how to best handle people with low reserve, and I think now I understand better, and we're getting much better rates, and we're actually putting together a whole new research publication on this whole area, because I think it's important to give that information to other doctors so that they're giving the best care for their patients.
Absolutely. And so really the bottom line, less is more here. Yeah. And so I'm just, again, not going to overlook this.
And cheaper, too.
And cheaper, a lot cheaper, a lot cheaper. Medication is a lot less.
And
100%.
you're getting as good. I have
Yeah.
patients that come to me, they've been to another clinic, they take $7,000 or $8,000 of drugs, and they get like 1 embryo or 0 embryos. And I give them less drugs and maybe a little bit of growth hormone as well. And they get 2 or 3 embryos, and they're going, Dr. Librach, I spent all that money on drugs, and now you've given me something that's way less, half the price or less, and I'm getting a better result.
So true. Yeah. And I see it. So, I see a lot of your patients, so I do see the difference too. But I also...
You help them too.
Yes, of course.
Is very important.
Thank you. And it's true. So, because I don't want to overlook that, is IVF the answer? It's one answer, and we do see people with low AMH naturally conceive as well. So, we can't... Just don't think that, oh, gee, I have low ovarian reserve and I need to only do IVF and that's that, right? So there are options, and you have to do with what's comfortable for you without wasting too much time, but simultaneously looking at your own personal lifestyle, your dietary habits, adding supplements, adding acupuncture. There's so many different ways of looking at this. So there are options for sure.
There's another very important point I want to make, and that is that a lot of women sort of put off having children. They have a career, and they're going to say, okay, well, when I'm 38 or 40, and you read all the Hollywood starlets having babies at 46, we know they're using an egg donor at that age, but most often. But and people will come and do what's called do the AMH when they're younger to see where they are, and that's helpful because it tells you kind of how much time you have left in terms of your reserve. You shouldn't put it off too long if you have a low reserve. The other thing people are doing now is freezing their eggs or embryos, depending if they have a partner. And I think that's a really good thing to consider. If you're sort of in your late 20s or early 30s, even 35 to 40, if it took that long to get to this point, to consider freezing your eggs if you're not ready to have children, because it allows you to sort of preserve your fertility for future, and especially if you have a low reserve, because although your success might be lower by freezing your eggs, if you have less eggs, you can also do more in one cycle and batch eggs together and still have a good chance. And nowadays we're getting more and more women who are sort of realizing that they don't have a partner, and maybe you find someone, it might take you 4 years to discover that's the right person to have children with or whatever. And so I think considering donating your eggs is a really good and smart thing to do. Now, I'm going to do a little advertisement. Actually, we make no money on this. We have an app that we developed, and it's free completely, so it doesn't give us any benefits, so don't think I'm advertising anything. It's called Freeze My Eggs, F-R-Z, My Eggs, M-Y, Eggs. So all one word. It's on Android or iPhone. And you can download it for free. It gives you kind of a way of looking at your understanding about freezing your eggs. It also gives you a little calculator. So if you know your AMH level and you know your age, which I'm sure you will, then, and even the antral follicle count, but that's not as accurate, you can plug that in and get an idea of how many eggs that you're likely to make if you freeze your eggs, and how many times it might take to be able to create enough to have a baby. So I put that out there. Actually, my wife, who interviewed you on Zuma Radio, she's a person who does a radio show every Saturday called Finding Your Bliss. At 1 o'clock. That is an advertisement. But she interviewed us on her show recently, and so she was the narrator on that.
Oh, fun. Okay, yeah. So, Freeze My Eggs, it's
That's
called.
Right.
Okay, all right. So you can check that out. Any last words of wisdom as women are trying to conceive?
I think it's really important to consider all the very important points I made during this conversation about the less is more approach, about not waiting too long to start your family if you know your reserve is low, even if you know your reserve is low, not waiting too long because of age effects, and finding a doctor that is open to different approaches, like the less is more, like the growth hormone, like the types of supplements we mentioned. Make sure the doctor you're working with is someone you feel really comfortable with and you think is going to work with you to really and take charge of your fertility. Like me, be informed. Like listening to this show, I commend you for just doing that, because you're hearing more information, maybe a different approach, and really do your research. Look into where you're going to get the best care.
That's really wonderful words of wisdom. Now, I do have one more question then I forgot to ask you. So in terms of taking DHEA, taking growth hormone, how long of a leeway, lead up before you do an IVF?
So for the DHA, CoQ10, PQQ, those are the supplements, the natural, vegetable-derived supplements I've mentioned. We usually, we don't really know the answer, but we know that eggs take about 3 months in your body to develop. So I would say at least a month or two before you start would be ideal. And once you start your cycle, that's another 2 weeks. So you're already adding another 2 weeks on. I think that's probably best because of the time it takes to grow your eggs in your body, to develop your eggs. So I think a few 2-3 months is probably more ideal. But again, as you're getting older, you don't want to wait too long. And then the growth hormone is something we don't give ahead of time. It's very expensive medication, so we use it only during the cycle as an adjuvant.
Okay, so just during the cycle at the retrieval time.
Yeah.
Okay.
I want to just also tell people, if you are going to be prescribed growth hormone, if you have a drug plan, there are unfortunately many insurance companies that do not cover it because it's an off-label use. It's used for pediatric people to grow taller. It won't make you taller, by the way. But so just be aware that you're going to probably be paying that out of your pocket for that.
Okay. Oh, that's a good.
You might be looking at maybe $1,000-$1,500 per cycle to do that.
Okay. All right. What is Sizin?
Sizin and growth hormone it's one of the forms of growth hormone.
Right, because I see people take Sizin before though.
Yeah.
Okay, interesting.
Yeah, there's an Omnitrope and Sizin are both companies that make growth hormone.
Yes.
So both of them are just the same
Exactly.
thing.
Yeah, because I see, that's why I'm like, Sizin is growth hormone, but I see people start it before.
Sometimes we do,
Yeah.
but it's very expensive to do it that way, and we do it with, and we get just great results.
Oh, that's good to know. All right, that's a really good tip, guys. So I hope you jot that down. So thank you, Dr. Librach, for coming.
It's been a pleasure.
Okay.
Mary, it's always great to talk to you.
Thank you. We'll have to have you back. We'll do more, right? Don't you guys want to hear him some more?
Happy to do that.
Okay, great. So before we sign off, like the post, share it to all your friends, neighbors, whoever, subscribe. to my YouTube channel if you haven't already done so, which is Mary Wong Acupuncturist, because after the Facebook Live post, which now will stay there, we upload it to YouTube, so then it's there forever and we can share more. So subscribe to that. And next Wednesday, we're going to be speaking to Susanna Dracul, who is going to be talking about her fertility journey, and she did utilize both IVF and Chinese medicine, acupuncture, and read my book Pathways to Pregnancy, and she had so much success that she decided to create an event. So we're going to talk about that later in terms of how she changed her ability to have hope and mindset, and now she's thriving and pregnant, which is awesome. So that's where we want you guys to be at. And just know that, you know, sometimes when we see others who have positive pregnancies, just allow that to be your hope, your beacon of hope, versus good for them, sucks for me, right? Because that's another way that we look at it. But I invite you to come from a more positive angle and say, you know what, that possibly can be me. And it may not look like the same journey, but what we go through is similar. So we're going to talk about that, and there'll be many more to come. And in fact, you can scroll down, there's now 157 videos, so you've got a lot of content. All right, so come back and let's have a little chat again next Wednesday, 8:30 p.m. Eastern Standard Time. Thanks. Have a great night. Bye for now.
Good night.